Welcome back to Your Health radio and television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and I'm so glad you could join us for this next segment. My next guest, the illustrious Dr. Michael Klassen, board-certified orthopedic surgeon. Dr. Klassen, thanks so much for being here.
Well, thank you, Dr. Morwood, for having me.
Dr. Klassen, very impressive resume. UCLA Medical School. Now, you know I did my chief residency at USC, so I'll forgive that little digression towards UCLA. So med school at UCLA, you train in orthopedics at UCSF here in San Francisco. You're board certified. You're a member of the American Academy of Orthopedic Surgery. And this is very interesting to me. You're a member of the Arthroscopy Association in North America. I want to talk about that soon. And you're also the team doctor for Cal State. Well, that's very impressive. Dr. Klassen, thanks so much for joining us. Let's talk a little bit about your background. You know, in medical school, we all rotate through delivering babies. We go through OBGYN, we go through internal medicine, and we do surgery. What attracted you to the field of orthopedics?
Well, strangely enough, the first thing I have to say is I went to undergrad at SC, so we have a commonality there. Why let me in UCLA Medical School, I don't know after going to SC.
So you went from USC to UCLA. That's right. Unbelievable.
Yeah,
okay.
They're not believing it at UCLA either.
I have to call the dean.
Let's call the dean. What attracted me? Actually, I got started in orthopedic surgery at UC San Francisco playing golf. So I was kind of a golf nut, and I still am kind of a golf nut, and that's what attracted me to orthopedic surgery, were the injuries like rotator cuffs and labrums and biceps injuries and all those kinds of things that we as golfers, even low back, like your last guest, Mark Young, was talking about. So those are the things that kind of got me interested, plus I like sports.
Well, you know, Dr. Klassen, when I was in training in residency and towards the end of medical school, it seemed to me that most of the people who went into orthopedic surgery were like the guys who were on the football team or the guys who golfed or swam, etc. It seems to just go hand in hand that those interested in musculoskeletal disorders are the active people, men and women, and who like sports. It seems to go hand in hand.
Absolutely. I think about 99% of my colleagues were either ex-athletes or weekend warriors, and high school athletes became weekend warriors, or college athletes, and even some professional athletes.
Dr. Klassen, what I want to talk about a bunch of things, and we only have about 18 minutes. But what I want to talk about, let's see if we can teach the audience to start the difference between an open joint operation, the way we classically did almost every operation, say 15 or not even 15 or 20 years ago, and now what we try to do, we try to operate through much smaller incisions, and you guys do a lot of arthroscopy. So let's, for example, talk about the shoulder or the knee or even the hip, and let's try to teach our audience the difference between an open operation and an arthroscopic operation.
Okay. Well, Dr. Morwood, the first thing is we need to learn a little language, and the language is arthros. Arthros is a Greek word that means joint. Scopy just means scope. So any joint you can actually put a scope in. So that's an arthroscopy. So we do shoulder arthroscopy, and you can even do toe arthroscopy. And there's guys that are trying to do that. Now, I don't do that. I do mostly shoulder and knee arthroscopy. But hips and ankles and all those joints are available to put an arthroscope in. The arthroscopic procedure is really just a tool on how we fix the problem. So, for example, if we're talking about a rotator cuff, a rotator cuff is a group of 4 muscles that surround the shoulder. There's one in the front, there's one on the top, and there's 2 in the back. And they bring the shoulder up in a position like we're going to throw a ball. And the deltoid assists in this motion here, what's called abduction. But the rotator cuff is really very important in stabilizing the humeral head. And this bone that comes up to your shoulder is called the humerus. It has a round head that comes into a flat space right here called the glenoid. And those 4 muscles and tendons of the rotator cuff surround that and make a cuff of tissue so that you can glide your shoulder through a range of motion.
Well, that's great. You know, my producer knows that I love these segments where I learn anatomy or I learn about something. And I really want to learn about the rotator cuff because I hear it all the time. I mean, this pitcher has a rotator cuff injury, or this golfer or this football player. So again, can we zero in on that and perhaps repeat what we mean by the rotator cuff?
Right. So the rotator cuff, again, is 4 muscles. And muscles are attached to bones by tendons. Ligaments hold bones together, and tendons move joints. So it's the tendon of the rotator cuff that we're talking about when someone implies that a certain person had a rotator cuff injury. It's the tendon, the muscle then attaches to a tendon that attaches to the bone. And usually the tendon is torn either off the bone or in the substance of the tendon. The muscle itself does not tear. So the four muscles that do that are one in the front brings us forward, one in the top brings us up, and then two in the back brings us back. So almost like we're throwing a baseball here and getting our elbow up and then slinging the ball forward. The rotator cuff assists with that. Now there's some other motions that happen in the shoulder that gets a little bit more complicated, like the humeral head slides into a different position, and the humeral head is held in the glenoid by a little gasket called the labrum. Now on top of the labrum is another tendon that goes off, and that's your biceps. And that's why labral injuries, which are most common in baseball players, biceps tendon injuries, and rotator cuff tendon injuries are sort of all come together in the shoulder.
So, Dr. Klassen, the labrum is sort of a gasket. Is that what you said?
The labrum is a gasket that surrounds a bone. The bone is called the glenoid, and the humeral head articulates with the glenoid. And around that goes a little gasket to suction hold the humeral head in there. And that's called the labrum, L-A-B-R-U-M. On top of the labrum comes the biceps tendon that you think of, oh, I hurt my biceps, or Charles Atlas is making his biceps bigger. So the biceps is on top of that, and then right on top of that comes the rotator cuff. And so sometimes the rotator cuff rubs on the biceps, and sometimes the rotator cuff gets torn and the biceps get stretched, and so those injuries can be concomitant, and we have to take care of them both at the same time.
Okay, now is it accurate to say that the rotator cuff is a stabilizer of the humeral head within, did you say within the glenoid fossa?
The rotator cuff's function is not to stabilize the humeral head. There are some ligaments that do that, some different ligaments called glenohumeral ligaments, and the suction of the labrum.
Okay.
There was a very cool experiment that was done where they actually dissected a cadaver, and they had the humeral head on there, and they couldn't get it off until they sectioned the labrum, and they found out it made a sucking sound, and it just popped right off.
Okay.
So it really acts like a gasket.
Okay, so then the function, could we assign a function to the rotator cuff? Is that for motion of the humeral head? Or
yes, it is, like throwing a baseball.
Okay.
So to get into a cocked position like you're throwing a baseball, you have to externally rotate your arm. Well, what externally rotates your arm are the two externals in the back, the infraspinatus and the teres minor, and they get one back in the position that we call the cocking position before the thrower comes forward. Now, when the thrower comes forward, there's a muscle and a tendon in the front that's part of the rotator cuff called the the subscapularis, and the subscapularis fires and pulls that arm forward. And so the external rotators in the back bring it back, and the internal rotators in the front bring it forward at a high velocity, and then that whipping action allows you to throw the ball. The one on top that we've neglected to talk about, the supraspinatus, which is the one that's most often injured, is an abductor to the shoulder. This motion is called abduction, A-B-D-U-C-T-I-O-N.
Okay.
So that's the function of the four units of the rotator cuff.
So is it correct to say then the rotator cuff is like a confluence of the tendons that come together to assist with motion of the...
That is correct. They aren't the anatomy that puts the humeral head in the shoulder, but you have to have a balance of the rotator cuff because, again, there's a muscle in the front and there's two in the back, and if they are out of balance, then the humeral head slides around too much, and now we get wear on the labrum.
Okay.
And now we have to go fix the labrum.
All right. Dr. Klassen, I appreciate that very much because that's about the most clear explanation I've been given since medical school of the rotator cuff. But my next question is, why do I keep reading about, there's two things I read about, anterior cruciate ligaments in skiers and football players, and then I continually hear about rotator cuff injuries in NBA players or in golfers, etc. So why is the rotator cuff so susceptible to injury?
Well, usually because the upper humerus is subject to a force, and that force may be either from an overhead activity. Let's say you're like one of our volleyball players that's out at Cal State, and those gals are hundreds and hundreds of times hitting overhead shots, or a tennis player that's hitting an overhead shot, or a golfer that loads their shoulder up in here. The humeral head then rotates in a way that the top tendon of the rotator cuff, which is called the supraspinatus, jams underneath this bone called the acromion, and that can cause wear and tear. Plus also, I hate to say this, but as we get a little bit older, the tissue becomes atretic, and you know as a plastic surgeon, the tissue is not as thick. That's atresia. It's not as thick as when we're a young person. So as we get older, that tissue becomes atretic. It gets smaller and thinner, like our skin does, and therefore it's not quite as tough, so it doesn't take much of a violent motion or a force against it to tear the cuff. And here's a real good activity that many people do that tears a rotator cuff that's unrelated to sports. It's reaching out in the back of your trunk to lift up those groceries where you've created a lever arm away from your arm here, and all that force is now on your rotator cuff, and those people are at high risk to tear a rotator cuff.
I see. Well, I appreciate that. So, now that we know about the rotator cuff, let's go back to the original question, the difference between an open operation, well, we can talk about the shoulder or knee, and an arthroscopic procedure or an operation.
Yes.
So I remember even 20 years ago, when guys used to operate on the shoulder, it seemed like such a recovery period and a long incision and so painful afterward.
Well, the reason to do arthroscopic surgery initially was for smaller incisions, therefore the less muscle would be violated and be easier to recover more quickly, and the rehab would be a little easier. But what's happened over time is we've gotten better techniques and better tools and better little screws and anchors and devices like that very innovative orthopedic surgeons have made a lot of money on patents, and it made the operations much easier, and so we can make smaller incisions and smaller incisions. So what we did in the old days is we made an incision down like this, and then we went into the shoulder, and looking at the rotator cuff with direct vision, we fixed it directly. We just sutured it just like you would suture any tissue in an open operation. Then what happened is we started putting arthroscopes in joints and figuring out the anatomy. And actually, a lot of anatomy was learned after the arthroscope became more commonplace in the shoulder. That anatomy wasn't known quite as good until arthroscopic surgery really took off. So the techniques got better. And so what we use is a fiber optic cable to provide light and to bring the picture back, and we watch it on a television monitor. So these surgeries that I do that are arthroscopic surgery are really like video games on the monitor, and we're making through 3 or 4 or 5 little tiny incisions. And actually we have little tiny sewing instruments, and we're sewing in there inside through little tubes, and the tubes are about as big around as my finger. So you're putting sutures down the tubes, tying them, and that's how you're repairing the rotator cuff or the labrum, for example.
Well, every once in a while, I'll be doing an endoscopic brow lift or something like that, and I'll slip next door and see you guys doing an arthroscopy, and just the digital effects and the screens and the images is really, it's startling how good it is. You can peer right into a joint, and you can see very small bits of anatomy, etc.
I personally think that arthroscopic surgery makes the shoulder surgery easier. It's harder technique to learn because there's a lot of hand-eye coordination. And I went back to Chicago and taught some orthopedic residents arthroscopic surgery, and it's more of a challenge seeing where they are on the learning curve. So once you get on that curve and you really understand how to do the procedures, you can actually see so much better. And the tissue, you can bring the camera right up to the tissue so it looks, so one little fiber looks as big as my finger here. And you have the ability to do that with your arthroscope. So the surgery, I think, is easier, and it turns out that the recovery may be easier because we don't have to make quite as big open incisions, and we don't have to violate tissue planes. We can just go right in, go exactly to the problem, suture it, drill a hole, put a screw in, put an anchor in, put a thread around it or suture around it. Any of those techniques are available, and they're much easier to do than the open procedure. In fact, I recently had to do an open shoulder. In fact, I did one today. It was a torture compared to the arthroscopic.
I understand. Well, Dr. Klassen, we've talked about sports industries, sports injuries, and talked about the surgery and operations for that. But what about, say, a carpenter who comes into the office and says that he thinks maybe in a week he'll put his arm over his head and bang in 1,000 nails, or a roofer, or one of the guys or women on a construction site who feels like they're always working above their head and they start to feel shoulder pain, and then it gets to the point where they feel they can almost not lift their arm anymore. Do you ever see people like that?
Oh, that's very common. In fact, more of those than I do athletes, just because there's more of those people out in the community than there are athletes. It's the same kind of pathology. It may have come more of a it may have come more of a chronic nature than just one traumatic moment, like throwing a baseball from center field, trying to throw it all the way to home plate. But it may come from repetitive chronic micro trauma. And those patients have the same problem, and we treat them the same way. It's just a different mechanism of injury. But the pathology is not that much different. And you still are going to go to someone who specializes in sports and arthroscopic surgery to do that.
Dr. Klassen, we've only got a couple more minutes, and I tell you, I appreciate this so much. I love these segments when I learn. I hope you come on again. I just want to ask you a couple other things. Tell us the difference between a shoulder separation and a shoulder dislocation. Like sometimes we'll be watching an NFL football game or an NBA game, and an athlete comes down square on the shoulder or the chest, and he gets carried off the field, and they say, well, he sustained a stage 3 shoulder separation, and then we hear about he actually dislocated the shoulder. So what's the difference between a dislocation and a separation?
Well, there are two different joints that we're talking about. When you say a type 3 separation, most commonly what the sportscasters are referring to, and they don't really, to be honest with you, they don't really know too much. The clavicle comes out and articulates with the acromion, the bone that's out here on the edge that holds the deltoid up. And where that happens, there's a little joint here. In fact, there's a little bump. That's the bump that the woman thinks it's made there to hold her bra strap from falling off. But we all have a bump on top of our shoulder here. That's the AC joint, the acromioclavicular joint. And if you land directly on your shoulder on the side, and believe me, every linebacker in the NFL is trying to drop the quarterback on his side to separate his AC joint, because if he makes about $10 million a year throwing a ball, they're going to bring in the guy who only makes $5 million a year. And so that's the separation that you're talking about. A dislocation, when we think of the true dislocation of the shoulder, it's not this joint. Now, it may be this joint. It can dislocate and be up here. But I think what you may be referring to is when they come out and they start pulling on the guy's arm. And what that is again, that humeral head that we talked about, where the rotator cuff attaches in the glenoid, has most commonly slid forward out to that joint, and it takes some effort to kind of slide it back in. And that may be what you're saying about a dislocation.
And that, it can actually come out of the joint.
Comes all the way out.
Wow. Dr. Michael Klassen, I do want to give out your contact information in case somebody has a question about shoulder pain or arthroscopy or some other orthopedic issue. Is that 643-9788?
Sure, that's our number at the clinic in Ryan Ranch.
So Michael Klassen, you're the team doctor for Cal State, board-certified orthopedic surgeon, 643-9788. Dr. Klassen, thanks so much for coming on the program, and most of all, thanks for teaching me.
Oh, thanks for having me.
Hope you come on again.
Anytime.
Once again, thanks so much for being here. I'm Dr. David Morwood. I'm a board-certified plastic surgeon, and this is Your Health radio and television program. We're coming right back after a very brief pause for a very good cause.